I call to order the meeting of the Health and Human Services Oversight Committee for Friday, June 26th, 2026. Would the clerk please call the roll?
Mr. Chairman, I've noted as present Representative Pearson, Representative Seaworth, Representative Mooney, Senator Rochford, Senator Long, Representative McDonald, Representative Woods, and Representative Weber.
Thank you.
I got everybody.
I do. And we welcome Senator Long, who is pinch hitting today for Senator Rosenwald. Thank you. Good to see you again. Next up is the draft minutes for approval from the May 29th regular meeting. Has everyone had a chance to read them over? In the absence of Senator Gray, would somebody make a motion to accept? Representative Woods moves to accept, and Representative McDonald moves to second. All in favor?
Aye.
Opposed? Thank you. Briefly, an informational update on behalf of the Commission for the Deaf and Hard of Hearing, the role of ASL interpreters for access to critical programs and services. This was a committee very ably chaired by Representative Porter. I took over for her for a few years, did some things that are within my wheelhouse, and then when the work started to become very much in an area that I'm not gifted in, I turned it over on an interim basis to Representative Woods. Would you make your brief report, please, sir? Yeah, I get to come to the high table.
Thank you, Mr. Chair and committee. I just wanted to take a couple minutes to identify that there is an issue which potentially could surface later on, but sometimes being aware ahead of time is helpful. And that is that the ASL program, that's the American Sign Language Program, is administered academically through the University of New Hampshire, specifically the Manchester campus. That program is the first fully accredited program in the nation, and it's still one of few that are maintain full accreditation. Because of a variety of factors, specifically identified with people who have applied in the past, the tuition at UNH has gotten to the point that they no longer feel they can participate. And as a consequence, there are only 2 out of a potential 20 who have actually put money on the line as of about 6 weeks ago. That has raised some questions about the program itself. What I mean by raise some questions about the program, that is its viability, and just for decision purposes, there has been the open discussion of the potential of losing that program to the state and what that would mean. As the interim chair for the Commission for the Deaf and Hard of Hearing, I've met one-on-one with the staff at Manchester. The last commission meeting we had, June 8th, we had the dean of the school in Manchester also, come to present and outlined that indeed there is a significant headwinds to keep this program going. That has a downside of potentially, and if I am saying anything incorrect, that's the reason I have Assistant Commissioner here to correct me, that there's a number of areas that come into play, specifically the judicial system and other ancillary services throughout the state that require for federal funds to have in place ASL program. If in fact we are not able to supply that, that raises some questions of whether these programs conceivably, secondarily, might fall into jeopardy. There's work going behind the scenes as we speak, both myself personally engaging with UNH and a variety of other modalities as to what potentially could happen, and even the concept of how can it be perpetuated if in fact UNH cannot be the prime provider. Can that program continue under another leadership? Work is in progress, but this is at risk at the moment. And I wanted, since HHS and Department of Education are by RSA deemed required to provide some ancillary services to augment this commission. Any questions? I'll let the commissioner offer any other comments, but I just wanted her to here to shore things up.
Sure. Thank you so much, Representative. My name is Ann Landry. I'm Associate Commissioner at Department of Health and Human Services. And while our work is really separate from the education programs at this school, I can just confirm that there is a high need for interpreter services across the state. Demand continues to go up. We're responsible for ensuring interpreter services for all of our programs and staff and beneficiaries within anything in DHHS, whether that's someone coming in for an interview or a client walking into a district office who might need support, as well as ensuring there's compliance with the civil rights law with all of our contractors and vendors who provide services. While we don't directly provide those, we ensure that they are meeting those requirements. And so just, I agree that there is there is a great need in the state and a continued need for interpreters and to have educated interpreters here in the state. To lose that would be very detrimental.
Representative Woods, in preparation to hand over to you, which I did today, the folders of notes from when I chaired this group. I was looking through them and I noticed indeed how many different items are by law required to have sign language interpretation. Court cases in one example. Another one is governor's speeches to the public. I've noticed, you probably noticed on network television, when Governor so-and-so is speaking, there's a little circle in the bottom where someone is signing that. I don't see that here, not because of any ill will by the governor, but you can't have what isn't available. So that's where we are now. And if this program is to go out of business, God help us all for these folks who need sign language. How can we help?
Well, at this juncture, just being aware, and if any of you, in fact, interface with the university system, would be much appreciated if you could drop a kind word and emphasize the comments that we've had here, and that the commissioners also made as well, would be very helpful. But it's a work in progress, and I'll keep you updated. But the watershed is somewhat significant, and as I said, potentially has financial impact as well.
Representative Weber.
Thank you, Mr. Chairman.
Thank you, Mr. Chairman, and thank you for taking my question. Could you just let us know, I got that it was 2 out of 20 have been willing to actually commit to the program this time around. How many years is the program? Is it a 1 year or a 2 year? And how many graduates do we normally have?
Well, the program is a 4-year regular baccalaureate program. To be ASL certified in the state, you have to have a bachelor's degree. So the ASL program, as UNH runs it, is a full 4-year baccalaureate program. Interspersed with this is the necessary, labs, exposure, practice, etc. You need to be competent as an ASL interpreter. So it's a full 4-year program. The number of graduates varies anywhere from 2 a number of years ago to up around 10 or 12 in a full program. But at this juncture, the anticipation is if it doesn't fill properly and there's no other ancillary measures, that there would be what's called a teach out. That in fact the people who are now registered in the program and are in 2nd, 3rd, or 4th year would be allowed to continue, and teaching and experience would be provided for them to complete their baccalaureate degree and be appropriate interpreters. But after that, it would fall by the wayside. If that comes to pass, I don't want to leave with the idea that that's what is happening already. We're trying to avoid having that happen. So any awareness and communication with the university system would be much appreciated.
I am aware of other programs in the state where people are learning sign language. For example, a couple of churches. I asked around and said, what is the purpose? And they said, oh, so churches could have sign language. That's not to say that those people thus trained couldn't do other things. That's the purpose. But my question is, if people were trained adequately enough through other programs, would they be eligible then in the state to sign a governor's press conference, to sign in a court case, or would they not be?
Well, that's a question over my pay grade. I wouldn't want to say yes or no. I know the requirements to be recommended for being an interpreter are fairly stringent, and there are programs like this that actually feed into the baccalaureate program, and specifically high schools. And I forgot the name of the high school in Manchester who actually has a program to teach kids ASL, and they learn that in high school, and that's one of the sources of students coming to the baccalaureate program. So there's that kind of outreach is in place. But as far as providing someone who's capable and could be recommended for interpretation as an interpreter, I'd have to sign off on that question.
As it were. Representative Weber.
So that brings up the question, you have the graduates of the baccalaureate program. Is there in addition a certification or licensure, and is that by exam or is that by simply qualifying as having graduated from an accredited program?
I don't know the details, but yes, there is a certification, and there's a certification board and a review board specifically independent of the university system, so that in fact that is accomplished without conflict of interest, shall we say.
Since you do not have a legislative race to contend for this summer, would you be happy to research some of that and get back to at least me, and then I can round robin it out to everyone?
We're in the process. Actually, we set up subcommittees, a variety of which are underway, and I've charged myself with heading the committee to look at legislation or at the RSAs. And there is a variety of RSAs in place, many of which significantly overlap. And I'm trying to sort that out as we speak in a variety of dimensions. But yes, indeed, I will provide an update.
And perhaps on a more private occasion, could you supply us with the names and contact information of the people you've already spoken to at UNH?
Sure.
So
I'd be happy to.
we can sort of say, hi, I'm a state legislator, I vote on your budget, I need a favor from you. Or words to that effect.
I'd be happy, and they'd be happy to talk to you, I'm sure.
Thank you. Anything else?
No.
Thank you for this.
No,
I'm sorry, Senator Roachford.
Thank you, Mr. Chairman. So just kind of piggybacking on what the chairman was talking about, I mean, it surprises me that this is a baccalaureate level position, quite frankly.
Yeah.
That's something I learned 3 minutes ago. Because prior to that, what I was thinking about was the community college system of New Hampshire would seem like a logical place to offer these types of services, given the fact that they're dispersed throughout the state. The bargain is second to none for tuition. So if we can get past that requirement, or if we know it's a requirement of a bachelor's level degree, it would make sense to me that perhaps the community college system would be a natural landing spot for this, for a variety of reasons: value, accessibility, just the role that they play in our community. So I would be interested, when you come back with the research over the summer, excuse me, to see if maybe there might be an opportunity there to partner with the community colleges in New Hampshire.
Yes, I've raised that question, and I put that on the table already, but thank you for the support in that venue.
Now, seeing no further
Thank you.
questions, thank you so much. We'll be hearing from you, I know. Now, before I call the next folks up, just a few comments from the chair about what we're going to be doing. It has been my pleasure to chair the Department of Health and Human Services Oversight Committee for the past 6 years. And I've come to know and appreciate the hard work and dedication of so many of the employees of the department. As we have come to trust each other, they and I individually have worked on numbers of issues needing attention, and I trust other legislators have worked with you as well. While bills and hearings are important, so also, I believe, is this quiet collaboration. Recently, Senate Bill 134 was signed into law, which sets our state's desires for how certain aspects of Medicaid will work. But recently, very recently, the federal government has released a document with some new rules. Since then, our Medicaid division of DHHS has been hard at work trying to see how the state's desires and the federal mandates can gel. Numbers of people have been consulted. Last Friday, a presentation was made to fiscal. Various tweaks were made to the handout, which we have gotten in the mail and you should have a hard copy of. This week, I've spent some time both on the telephone and also on Teams meetings, further amending the document. The document you have, and I think got in the email, is the latest iteration. The Senate bill, knowing that legislative policy committees and voting sessions would be finished by now, gave the voting on some of these Medicaid matters to this committee. With that in mind, I welcome Olivia May and Ann Landry, and would you please come up and tell us who you are, what you do, what your titles are, and so on.
Good morning, Chairman. Olivia May, Deputy Medicaid Director.
Good morning, Ann Landry, Associate Commissioner. Olivia and I are grateful to be here today, and the two of us, along with Dr. Jonathan Ballard for different parts, are here to update this committee on some of the changes that have come out of the interim final rule that was released on June 1st regarding the community engagement / work requirements for Medicaid. And as Chairman Pearson mentioned, the approval process from this committee for some of these changes and what DHHS in the state of New Hampshire needs to move forward next. And with that, I'll turn it over to Olivia, who is our expert here and is going to walk us through this.
So I'd like to focus on the summary document that we distributed to the committee in advance of this meeting. But for some topics, I might reference the slide deck that we also presented, since that provides some supporting detail depending on questions and interest of the committee.
So the two items will be that slide deck and then the 1.5 page long one-pager that
Correct.
walks us through exactly what we have to vote on. Yes, so we should have those kind of side by side.
Yes, if
Thank you.
that works for the committee. Thank you.
And just for a minute, so this is what we're looking at for the slide deck, is that correct?
Yes. Does it
Okay.
say work?
Oh, no,
no,
that's
that's
the
the
adult
dental update.
dental,
Apologies.
sorry.
Okay.
We have copies. We could distribute the slides.
I will need 2 copies, one for me and one for the record. Okay. Yes, that one I could find, and this, because this is health status. So yes, thank you very much. Got it. Sorry for that.
No, thank you for identifying that.
Genuinely didn't have them, so.
So I'd like to just begin by recapping the background for the purpose of our presentation today. Senate Bill 134, as mentioned, was enacted prior to the availability of this final rule related to the federal requirements for Medicaid work requirements, which is also called community engagement requirements, but it refers to the same policy. In the One Big Beautiful Bill Act, also known as the Working Families Tax Cut Act, or HR 1, passed federally last summer, there was contemplation that there would be a rule introduced by June 1st by CMS to define the policy parameters for Medicaid work requirements. That final rule was published June 1st, and so the department reviewed it in comparison with Senate Bill 134. Really what we're looking at today is what remains as the policy decisions to enact Senate Bill 134, given the parameters and policy in the final rule. There are many areas where they perfectly align, and I would say I was a little bit shocked at how that was possible, since it wasn't published at the time, or even the law was published at the time of Senate Bill 134. So that was a relief to see many areas of total alignment. So we're going to go through 3 topics. The first topic is pertaining to the short-term hardship exceptions. These are optional short-term hardship exceptions made available in the interim final rule. The interim final rule did set the requirement that states must elect to adopt either all or none of the 4 short-term hardship exceptions. The 4 short-term hardship exceptions are for individuals receiving inpatient or other institutional services, for individuals residing in a county in which an emergency is declared by the president, like a natural disaster, individuals in a county or other region where the unemployment rate persists above 8% or 1.5 times the national unemployment rate, and those who are traveling extensively out of state to receive serious or complex medical care that's unavailable in their community. We don't anticipate 2 or 3 to arise, but I think the first one, particularly to those who are inpatient or receiving institutional care at time of application for Medicaid coverage, we felt that this would be favorable to adopt in the state's policy. And given the federal requirement that it's all or none, our recommendation would be to adopt all. This short-term hardship exception would be a temporary exception from the Medicaid work requirement at the time of application and at the individual's next redetermination or renewal of eligibility. If they're no longer inpatient, that would no longer apply as an exception to them.
In my conversations with Mr. Lippman, he went on at some length about various aspects of it, and I drew a conclusion that there was a few items where if it's very clear very soon this person's not going to comply, that person's cut off, rather than wasting a lot of money on somebody like that. But if a person cannot quite do it because of these real reasons, we want to be compassionate towards that person. So to me, that was almost a fiscally compassionately wash. You are not overly helpful to those who shouldn't be, but you are helpful to those who should be. That was my takeaway. So I put it in a sentence to him. He said, yeah, that pretty well sums it up. Representative Mooney.
Thank you, Mr. Chairman. Thank you both for being here, and appreciate the explanation on these 4 points. You know, the big concern as a legislator, obviously going into the area of exceptions, is the exceptions swallowing the law. I don't really see that as a concern here with these 4 points. However, I am interested to know if you know
what the unemployment percentage rate is currently in the 10 counties of our state?
I do not have those figures. However, we did review to see if any of them would come close to meeting this standard, and they do not. So that's why our expectation, again, I don't want to invite negative events, right, by saying this, but item 2 of the emergency declared by the president has been really heavily taken up by the southern states where there are more weather-related events that trigger that kind of declaration. And on 3, again, based on historical data, we don't anticipate 2 or 3 coming up for our population.
Thank you.
Senator Rochford.
Thank you, Mr. Chairman. And so I did want to park on 2 things. One was the emergency declaration that you mentioned. And I, a lot of this, my question probably centers around my lack of understanding and knowledge about really what an emergency declaration is. Sometimes we see those, we have a bad snowstorm, and the state cleans it up, and then we have a retroactive emergency declaration. 2 years ago, my part of the state, and among other parts of the state, were hit really hard, almost 2 years to the day, with extensive flooding, and I believe there was a declaration there at that time. So I don't know. So let's say there was a declaration. We have a horrible flood. We have a declaration. Does this exemption apply only during the time of the emergency, or does it extend it beyond that?
It is tied to the emergency
Okay.
event. And I will just emphasize it's a declaration by the president. So an emergency declared at the state level would not qualify. It would need to be a federally recognized.
And I know during 2 years ago, they were petitioning the president to do that. And if I have a follow-up, May? So the other one is number 4. And I totally get the premise of this, totally understand the premise of this, but do we have a definition for extensively?
So I think that the 4th category for traveling extensively to receive medical care, that would be an area where, the state, I believe, would have some ability to define that in more detail for how we actually put it into practice. We can definitely provide, everything that's described in the federal rule, but the spirit of the federal rule is really, again, similar to the national emergency. It's tied to that episode of care that requires someone to go out of state. And so extensively really means more like that there's a acute medical need to get this care somewhere else that's unavailable in your community, and it's out of state, far from where you live, preventing you meaningfully from completing 80 hours of qualifying activities.
Right. And I guess, and it's not going to affect my vote today. I would like to see some
That's a great
definition
question.
behind that,
Yeah.
because extensively, somebody getting treatment at Dana-Farber from Hudson or Salem is a very different situation than someone getting treatment from Dana-Farber at Pittsburgh or Clarksville. And, so I think that would, we want to be careful what extensively means in regards to our makeup of our state and where the people in our state are living and how far they have to travel.
To quote from the federal rule, it's an extended period of time to receive medically necessary services to treat a serious or complex medical condition.
Yeah, and extended period of time means a lot of things to
Sure.
a lot of people. Yeah, thank you.
Senator Long.
Thank you, Mr. Chairman, and thank you for the presentation. Still on number 4, definition for extensively would be nice. And also receive serious or complex medical care. Do we have a definition of what that is?
The interim final rule does not rigidly define that, but I think these questions are great feedback for the department, that if we were to receive authorization to adopt those exceptions, we need to be very careful about how we define that in practice to make sure that we're really targeting a complex, serious medical episode. Again, to your point, Senator Rochefort, is extending for longer than like intermittent outpatient visits, right? That you're needing to reside essentially somewhere else to receive this care.
Okay, that's good. Thank you.
Representative Weber.
Thank you. And I just to extend from that, I'm thinking, I am assuming that the department if authorization is received from the federal government, the department can then engage in rulemaking under the federal parameters that will clarify the issues raised by both Senator Rochford and Senator Long. For myself, I see this as being, as our chairman said, a compassionate extension of care. It's clear that if somebody's actually full-time residing in an institution where they're being cared for, that a community engagement is not going to be particularly successful, and they're the people who need the coverage, and this seems to me to be an extension of that. We have a lot of rules where people qualify for services in home when they're homebound, or they qualify for services also when they're institutionalized. And there's a rub between that and the people who actually have to travel for care. And they're not strictly speaking homebound, but they're not strictly speaking in the workforce or doing anything other than traveling for care either. And I think that I'm really pleased that the federal government has recognized that, and I hope that the rules that are ultimately promulgated will make those a little more clear, but allow, I speak as somebody who has experience in this area, of somebody having to travel for medical care, and the difficulties that families and caregivers and everybody else has to go through to get that to happen. And so putting more roadblocks in their way would be very unfortunate, and having a good, strong definition so that people who need the exception get it, and people who don't would be very helpful. Thank you.
Thank you. Representative Woods.
Thank you, Mr. Chair. I just, again, pointing toward definitions, and it may be included perhaps in rules, and that's in one, inpatient or other institutional services. There's a lot of, significant difficulty of people, especially with cancer treatment, or infusion therapy, and that's not done it sometimes is done in hospital, but is often done at an infusion center, and sometimes a sequelae of not just the 1 day per week with infusion. Sometimes you're sick enough for 2 or 3 days afterwards that you can't work. Is that included under the institutional level of services?
To read from if I may, the interim final rule, it's inpatient hospital services, nursing facility services, services in an intermediate care facility for individuals with intellectual disabilities, inpatient psychiatric hospital services, or other such services of similar acuity, including outpatient care, relating to the preceding institutional services.
Super. Thank you.
Does that answer your question?
Yeah,
okay, thank you.
Would it be possible for the division to come up with some rules or suggested rules? And I know rules go to JELCAR, but could they also come to us in a subsequent meeting, which arguably could be in August and definitely will be in September?
We would welcome the opportunity, of course, to present on initial frameworks for administrative rule. We are tentatively aiming to seek JELCAR approval on administrative rules by December to be in line with the federal timeline for implementation. So I think that gives us good, runway to present to this committee.
Senator Long.
Thank you, Mr. Chairman. Does Senate Bill 134 require 548 JELCAR? Or does that need to be added in?
So Senate Bill 134 doesn't speak to administrative rules. I think like any federal policy, we would look at the available federal law and rule, state law, but many administrative details get defined and enacted in our administrative rulemaking process. So we anticipate the need, just like any major change to our program, to update and maybe introduce new administrative rules, as the case may be, to formalize the policy.
Okay, follow up. So there isn't a need to require to put in statute JELCAR. That's already there.
No.
Okay, great. Thank you.
The chair elects to do severability here and do the three different things as three different things and not as one vote. So with that, the chair will entertain a motion to accept number one. So moved and so seconded. Any further discussion? Senator Rochford.
Just real quick, Mr. Chairman, thank you. Just going back to how you introduced this when we started this discussion, you said this went to fiscal. You've been in discussions over the last couple week or two. Are we looking at the changes or the additions or the clarifications that happened between fiscal and today? Or
Between fiscal, me, and today.
So
the slide deck came after my last conversation.
okay, that's
with
what.
them.
Yep, that's
I
what
wouldn't
was
sneak one in otherwise.
All right. No, I just wanted to make sure
But
we knew what
You
fiscal.
you weren't saying that, but I will
Yep.
say that.
I just wanted to, I guess, reconcile what fiscal
Mhm.
and what we're doing and what the differences are. So thank you.
You're welcome.
Answers my question.
Any further discussion? Then do we need a roll call or just a voice vote?
Well, why don't I just go around and name people and we'll do a roll call just
Okay,
in
use
case.
use the names they came in with. Okay.
Yes, I
Yeah,
will
you'll
not
do
call
that?
for Representative
Different-
Senator Rosenwald,
No. Okay.
but Representative Woods, Senator Rochefort, Senator Long, Representative Mooney,
Yes.
Representative Pearson,
Aye.
Representative McDonald,
Yes.
Clerk votes yes, Representative Seaworth.
Unanimous. There's one. Item number 2, assess compliance with community engagement requirements for 1 month within every 6-month eligibility period and align verification with the 6-month redetermination process, which was an exhausting conversation.
Yes, thank you in advance for getting into the details of this with us today. So the second item pertains to policy elections that states must make for really what I think of as the cycle of assessment and verification of someone's compliance with work requirements. There's 2 pieces to this. It's how many months are assessed in that verification process, and how many occurrences of verification take place. In 2027, and this was not, I don't believe, formally established at the finalization of Senate Bill 134, in 2027, the population impacted by work requirements will move to redeterminations every 6 months. Currently, they're redetermined for Medicaid annually every 12 months. And the interim final rule that was released June 1st advises states that if they seek to conduct a more frequent verification within that 6-month eligibility period, in other words, verifying more than once in the 6-month cycle, states will be at risk of still processing a verification into month 4 while at the same time initiating the next verification. And there's 2 sort of major consequences of that. One is, of course, just the beneficiary experience, right, of navigating which verification they're completing and what the status of the last one is and what they're doing to prepare for the next. The other major consequence to highlight is it puts the department at risk of not being able to take action on individuals who are not compliant. So because the whole process kind of start to finish is about 3 months to notice someone that we found them out of compliance, to seek more information, SB 134 and the interim final rule require a 30-day noticing period to give individuals an opportunity to respond and provide that supporting documentation. We would be at risk of having received documentation that we need to respond to in order to compliantly close a case. In other words, to say, you haven't given us sufficient information, we need to close your case for noncompliance with work requirements. So the department's assessment, looking at the federal rule, our operational policy, which we can get more into if the committee is interested, is that to really be able to feasibly implement this, we would recommend a 1-month assessment in that 6-month period and aligning the timing with the 6-month redetermination process. And that would enable us to close someone at the end of their 6 months once we establish that they can't demonstrate compliance with work requirements.
Senator Long?
Thank you, Mr. Chairman. Is there a specific month? Is it the first month that you would be looking at?
It's not necessarily the first month. I will say in practice, we're hoping to use things like quarterly data from employment security, right? Data that's available to us on people's work activities. So if we're using available data, which Senate Bill 134 and the interim final rule requires us to do, it may be the first month, right? Because that's what's most likely to be complete at the time we start assessing. But it doesn't have to be the first month. So if we don't find something in our available information that shows that they're doing the work requirement, they could provide us documentation for the third month or the fourth month, to demonstrate that.
Very good, thank you.
Yes. Who? You? Oh, sorry. Yeah, you, Representative McDonald.
Thank you, Mr. Chairman, and thank you for being here and taking my question. Or actually, more of a comment than a question. Having been in the department for a long time, I know that the accumulation of verifications and the processing of verifications is a pretty significant, extensive, laborious process. And I guess it's more of a comment than anything. And this makes total sense to me that you would want to do this, and I would recommend that we support it.
Following up on him before I call in Representative Weber, we had in either it was one of the phone calls or one of the team meetings or whatever, an extensive conversation on how one state insisted to do it a certain way, and that meant Indiana had to hire 400 more people to do it. And I mean, I thought they were smarter than that, frankly. So what you're trying to do is do the best job you can without having to hire all these people, which feeds back into your comments.
That's right. There is only one state currently publicly, contemplating the more frequent verification approach, which is Indiana, and they've publicly stated they're posting 400 new positions. They are larger, in fairness, a larger Medicaid program to us. But if we sort of adjusted it by total Medicaid enrollment, it would still end up to be about 40 positions for our program.
Representative Weber.
And mine is also a comment that I'm coming at it at the same conclusion from the other direction. The concerns I get from constituents and the concerns I get sent to me from other representatives who have constituents with problems either qualifying or staying on Medicaid is the requirements for the documentation, and it's incredibly onerous for the people who are undergoing the determinations. For some, it's easier. I mean, if you just have the records from employment security, that's relatively easy. But for some people, documentation becomes a real hurdle, even when they are very appropriately qualified, but being able to show the qualification is difficult. And that happens under many different scenarios, some of which don't apply here, but I really appreciate on behalf of the people needing the coverage and qualifying the coverage, the effort to make it as simple as possible for them to demonstrate that they qualify, because my concern all the way through this has been for the person who is in all real world situations actually qualified but can't actually get it together to provide the documentation. So I really appreciate the effort on your part.
Thank you for that.
Any further questions? Any further questions on number 2? Again, I will just say that this took up a good portion of my engagement with this. And again, I really appreciate the effort to try to square circles. That's where I live.
To describe it.
Now, this, should we pass number 2, are we okay with the federals, or do we need a waiver from the federals, or what?
We do not need a waiver.
Okay, so we're okay. Just wanted to nail that one down.
Sure.
Good. Representative Weber.
I would be glad to make a motion if you would care to accept.
I would care to accept it.
I move that we accept number 2 as detailed and described to us.
And Representative McDonald seconds it. And when ready, the clerk may call the roll.
Representative Woods, Senator Rochefort,
Yes.
Senator Long, yes. Representative Mooney,
Yes.
Representative Pearson,
Aye.
Representative McDonald.
Yes.
Clerk votes yes. Representative Seaworth.
Yes.
Thank you very much.
2 is passed.
Thanks.
Now pinch hitting for Assistant Commissioner Landry is Dr. Ballard.
Yes.
Item number 3, align the review of medical frailty in the first year, 2027, to the allowed approach in the federal rule, while concurrently running an algorithm of diagnoses to assess the degree to which resources are needed to address the expanded assessment of frailty.
Good morning, Mr. Chairman, committee members of Health and Human Services Oversight Committee. My name is Jonathan Ballard. I work as the Chief Medical Officer at the Department of Health and Human Services. So what this item relates to are the specific medical conditions that are included in the law for exemptions from community engagement. And there are a few conditions that are listed in the law that were somewhat specific that we have been preparing for over the past 6 months. The conditions are blind, a actively treated substance use disorder, and a disabling mental condition, intellectual, physical, or developmental disability that impairs activities of daily living, and then a serious or complex serious or complex conditions. What we're proposing to you in this item number 3 is a pragmatic approach, considering some changes that were provided on the June 1st interim final rule. The interim final rule expressed to the states that we need to think about exemptions for serious or complex conditions in the context that the condition, this is on the PowerPoint on page 9, as significantly impairs the individual's ability to comply with the community engagement requirement. So that's a degree of functionality. Does the serious or complex condition impair the ability functionally or intellectually to comply with community engagements? So that throws a little bit of a curveball for us, because in conversations with other states and having active conversations with all other states on this topic, and the law states that we shall use ex parte data and use a data-driven automated approach to this. And medical claims data does not get to the level of functionality of an individual. It may tell us the condition, but it does not tell the functionality. In subsequent meetings with CMS and publicly listing how we can comply with the interim final guidance, they have expressed to us a practical approach, which we are presenting to you today to allow us to pursue. And that is to use the claims data with the underlying serious or complex condition with additional data that may indicate the functionality of an individual. They stated there are certain standalone conditions that would automatically state, or in a clinical perspective, that you can say that condition surely does not allow the person to comply with community engagement requirements. They listed specifically stage 4 cancer, that a person with that degree of cancer is functionally oftentimes unable to work or comply. So that may be straightforward, but if you think about other conditions, like say stage 1 breast cancer, for example, that's a time when a person would be in a setting where they would be initially undergoing treatment, lots of doctor's visits, may have to undergo a double mastectomy, may have to start chemotherapy. I think that would be another condition that you could think of reasonably. But in order to comply with the federal rules, we need to think of the underlying condition plus data like, are the person on infusions? Are they on serious medications? Are they hospitalized? Are they having frequent emergency departments? Are they requiring significant amounts of durable medical equipment? So that's how we have been advised by CMS to think about medical frailty. An alternative approach, which some states are pursuing, is to do actual individual assessments, doing additional functional capacity evaluations, meeting with clients, hiring clinical staff as a state. The state that is thinking of this, that's publicly listed, it was Montana. Montana is hiring a little over 60 employees, to some which would be clinical. You saw Indiana earlier, over 400. So what we're thinking about offering to you is a pragmatic approach, is to do the clinical data and evaluate over the course of the next year how that actually aligns with individuals who are frail. The interim guiding, the final guide rule states that for the next year, we can, in our eligibility application, the time of application and renewals, ask individuals under the pains and penalty of perjury if their provider has indicated to them that they have a disabling condition, serious or complex condition that would cause them an inability to comply with the work requirements. So what we're proposing to you in this situation is to ask and verify. Ask the clients, the beneficiaries, if they have that, and then give us the time over the course of the next year to fine-tune our algorithms. That way we don't actually miss anybody that would justifiably meet the exemptions under the HR1 law.
Representative Weber.
Okay, so I'm thinking back to my very first term in the House, and Representative Mooney and I were on the same committee, so she will remember it as well, when we had a bill about the capacity of people with developmental disabilities to execute advance directives. And the goal was to protect people from being coerced in any way. So it was a recognition of a frail population, and it basically said that they couldn't do them. And I sat there with hysteria rising in the back of my throat when I realized that the very able chair of our committee also had a developmental disability, which interfered significantly with his mobility, but interfered not at all with his ability to make his own medical choices. And so this question of how we filter out, because each condition takes each person differently, is one that boggles my mind as to how you develop. I'm not good on algorithms anyway, but am I understanding that after you have done this period of verification for a year, that we will then just have a set of parameters where you qualify or you don't qualify? Or will we going forward have a mechanism by which somebody can determine, yeah, it applies to this person but doesn't apply to this person because of whatever is going on?
Our goal is to be able to use, the available data that's reliable and conforms, right, to the definition that we have in front of us as much as possible, because it automates the process for applicants. It prevents action needed to be taken by providers to document things that they may have already documented to us in claims that they submitted. And it prevents, the manual work needed from our eligibility staff. So while our goal would certainly be to, in that second year, to be as tuned as possible to do that by verifying the data we have available, I'm sure there will always be cases where there's still a need for individuals to supply us, information, just because we may not have all of the information submitted otherwise.
Okay. It just, if I may, Mr. Chairman, it occurs to me that there are going to be exceptions in both directions.
Absolutely.
Yeah. I was able to drive myself to Concord 4 days a week after breast cancer surgery. Other people are simply not able to do that. And so, you know, on the one hand, you have people who are not being shut out and who are able to continue to do their community engagement. On the other side, you have people who, although on paper may not look so needy, but in practical events, you know, it depends. For example, in breast cancer surgery, whether it's your dominant side or your non-dominant side makes a huge difference, and the placement of the tumor, the size of the incision, all of that, you know, is just different from person to person. And that, I guess I will just compliment you, because that multiplied by the number of people applying and the number of different conditions that they have is something that to me kind of boggles my mind.
Yeah, and Dr. Ballard may expound on this, but I think that is sort of the challenge ahead, is to, you know, like Dr. Ballard said, it's not a flat, you have this diagnosis, therefore this is your ability to work. We're going to need to use, you know, column A, column B, column C, different indications, not just of an underlying diagnosis, but what services someone is utilizing, what drugs they may be on, you know, what assessments have been done on them related to those services. We'll need to combine details in that way to make a more targeted assessment of what, you know, what might be reasonably doable for their ability to work or, you know, be a student and the other qualifying activities. Do you want to add anything?
Senator Long.
Thank you, Mr. Chairman. Now, does this apply to both working conditions and community service?
Yes. Yeah. The way the policy is structured is you meet the requirement through any combination of qualifying activities, which can be a student, paid work, community service. And so there isn't really a way to make unique, you know, qualifications and exemptions per activity.
Okay, thank you.
Yes. You may ask a question. I thought you were going.
No, no.
Okay, use the other hand.
Okay, I'll use this one. All right. Thank you, Mr. Chairman. You mentioned that one of the approaches some states are using, like Montana, are individual assessments. But given the budget constraints the department's been experiencing, budget cuts and so forth, that's not really an option here, right? I mean, I wouldn't think.
It is not. That's why we put forth this more pragmatic approach for the time being.
That's what I thought. Thank you.
Representative Woods, whom I thought Representative McDonald was pointing at.
Thank you, Mr. Chair. Thank you, Representative McDonald.
I wasn't pointing to you, but I'm glad he thought I was.
Just a slight concern. This sounds obviously logical to do. Is there any sense of any risk of the feds looking at this and say this really doesn't meet our criteria, and this is overstep or whatever you want to call it, and run into halting the whole program?
I think this speaks to Representative Mooney's comment earlier that the federal government was interested in not undercutting the law with excessive exemptions. And so this is actually what they're telling us in the interim final rule of how we should be approaching it.
You feel comfortable with that? They would, but I always hesitate.
You use the term interim final, which, from my knowledge of the federal government, is a very apt phrase. How interim do you think these final rules are before the next interim final rules supersedes it?
CMS has talked about actually presenting to us a code list and their own algorithm at some point in time in their conversations. It's not final that they will do so. I have no indication there are additional rules coming, though.
No, there is a comment period associated with the federal rule, but all of the indications we've received is that, you know, it's a regulatory obligation. We're not anticipating large changes from what's been released.
Thank you. Representative Rochford.
Thank you, Mr. Chairman, and it's a senator now. So
Thank you, Senator Rochford, and congratulations. I never did send that card, did I?
I know. So I thank you, and I see this as a roll-up implementation strategy, and I totally understand where what you're proposing in 2027, looking to 2028. If you could just get into the functionality of that, what's that going to look like? 2027, it looks like a softer touch. 2028 would, based on what we're hearing, would be a more robust approach. But I guess I'm not really grasping on what 2028 will look like functionally.
And are you asking that in particular to the medical frailty topic?
Yes,
we're happy
exactly,
to speak to that. So we are working on that now. We're building new interfaces between our eligibility system and our MMIS, the Medicaid Management Information System. The MMIS has connections to all three of the MCOs and counterclaims.
Could I just ask you to slow down for a minute and say what the two things are that we're interfacing again, please?
Absolutely. Sorry, you got me excited and I went. So we have an integrated eligibility system, which manages the applications and status of everyone's program eligibility. We also have a system that is essentially our claims platform for paying providers for services, but it also connects to the 3 MCOs and the dental managed care plan to retrieve and store their claims information as well. It also stores information about their provider networks, authorizations made on services and drugs, their pharmacy benefit managers. So it's really the repository of most of the clinical data available to the department as a Medicaid payer.
And that one is called what?
MMIS.
Standing
Medicaid
for?
Medicaid Management Information System. And so today, the eligibility system.
I'm sorry, Medicaid Management Information System. Thank you.
So presently, the eligibility system does not intake much around that clinical data, right? It doesn't have a reason to. With the medical frailty requirement, what we'll develop is, like Dr. Ballard mentioned, an algorithm that sets parameters to retrieve matches through all of that clinical data and identify people who are enrolled in the program who would meet that criteria that we're trying to work on and hone to establish that they may meet the medical frailty definition. So in terms of what it will look like, as we approach everyone's redetermination date, that system will run, that algorithm will run on a member file between the systems, and the eligibility system will get an indication from the MMIS of who has matched those criteria and parameters on current, reliable, recent data. If there is a match, so to speak, we will be able to ex parte or passively apply that exemption. We would notify the individual, and then they would not need to take action to kind of formalize that exemption. If we don't have that underlying information, so to Representative Weber's point, if someone maybe is medically frail, but for whatever reason our system can't identify that, then they would be supplying documentation directly to the eligibility system. And that's what, some states are undertaking is, like, for every person, taking that documentation and manually reviewing it with, like, a clinical staff. Does that illustrate a bit?
Absolutely. Okay. And if I may follow up on that, Mr. Chairman. So looking at 2028, and I know short of hiring 40 people, do you have the resources available within your budget to implement the 2028 plan as is now?
Yes. Okay. In terms of, like, what it takes technically, we have the capability to do this. I mean, we're working on it currently, and it's going to take some time, but there's no new system needed or amendments or anything like that. I think really, to Dr. Ballard's point, like, the challenge is refining those criteria. Once the criteria are refined, it's the same process to apply them.
So we're not going to get asked 6 months from now for $5 million to,
no.
You've got that money. Okay, thank you.
used to be Representative, but now Senator Long.
Thank you, Mr. Chairman.
We'll forgive you.
Uh,
In the corner.
Yeah. Yeah, just, I mean, it's not clear to me, but I'm looking on page 5 of the presentation, specified excluded individuals and exceptions. The under age 19 and the under age 14. Are there differences with those that are under 19 or the 18
Yes.
and under?
So it's difficult to lay out this information simply, but under age 19 is really a statutory conflict that if you're under 19, you almost certainly aren't in the Granted Advantage healthcare program, so this won't apply to you. But this just sort of formalizes that the expansion Medicaid adults are over 19. So if you're under 19, you're accepted. The 14 age refers to someone who is in Granted Advantage. They're in that expansion adult population, but they're a parent, guardian, relative, or family caregiver of a dependent child under age 14. So that dependent, whether or not they're even on Medicaid at all, needs to be under 14. Does that address your question?
It does, yes. Very good, thank you.
Any other questions on 3? The chair recognizes Representative Weber for a motion,
I would move that we would accept criteria number 3.
and former and present Representative McDonald.
Second.
The clerk may call the roll.
Still getting the moved and seconded in here.
And present.
Representative Woods. Senator Rochefort.
Yes.
Senator Long.
Yes.
Representative Mooney.
Yes.
Representative Pearson.
Aye.
Representative McDonald.
Yes.
Clerk votes yes. Representative Seaworth.
Yes.
Thank you.
The motion passes. Representative Woods, you and I are the only ones who said aye. I think the Tartan Army has left Boston now, but wow. I mean, I'm 1/4 Scot, and I really got my Celtic blood going while they were in town. All right, before the next one, a little prologue. For 25 years, no Medicaid dental bill had passed. 3 years ago, Representative Shapiro of Cheshire County asked me to take point in the House on his bill on Medicaid dental. And as one looked at the bill and reviewed previous public statements, the bill was very good on compassion, but I wondered if some people found it difficult to exercise compassion if they saw it to be a colossal waste of money. So as some of you remember, I went to the floor and spoke about my Uncle Dick's truck that seized up for lack of an oil change, making the point that sometimes you can be penny wise and very pound foolish. I needed 10 Republican votes, I got 94. And so many of those folks came up to me afterwards and said, look, I think I'm a compassionate guy, but I got to save money too. And you showed it can be done. And a lot of what we do is, maybe this is irreverent, but I call it conservatives with a heart and liberals with a brain, or it is people who are compassionate and frugal at the same time. It can be done. We've demonstrated that in the House and the Senate a lot of times. Then Senator Rosenwald, and we're going to miss her, got it through the Senate. And we made a good start, and Dr. Sarah Finney was the dental rep who would come to us. I'm told she's of an age where she's now taking care of the grandkids, or as I prefer to put it, Dr. Finney's gotten long in the tooth. That was a dental joke. So anyway, with that in mind, the chair recognizes now Dr. Barry Chang, the new Medicaid Dental Director, and recognizes back Olivia May, Deputy Director, Division of Medicaid Services. For your presentation, an update.
Hello again, Chairman and members of the committee. I have with me today Dr. Barry Chang, who has joined the department about 1.5 years ago, stepping into our dental director role. It's been a pleasure to have his fresh perspective on the program and leadership. I'm going to just make a couple remarks to kick off the presentation, and then I'll hand it to him. We provided some slide handouts for the committee on the dental program. Just to refresh on background, on slide 2, we presented a national map of adult dental Medicaid coverage nationally. So we are one of 42 states, as well as the District of Columbia, offering adult dental benefits to at least some of the populations within Medicaid. The states in yellow are only covering emergency dental services.
And
yep.
If I may, Mr. Chairman, in your comments, please remember that we don't have them in color.
Oh, I apologize for that. We have color copies. I should have redistributed that. My apologies. Well, hopefully there's enough contrast between the yellow.
It's quite all right. It's just you need to use other hues.
Yeah, great point. Thank you for that.
I don't need it. I don't need something different. I just need the cues to be keyed to what.
No, I appreciate that. That's very helpful. Slide 3 just is a refresh of just the structure of how we deliver benefits in our Medicaid program. So if you think about, a family on Medicaid, the medical and behavioral health services are, for most individuals, administered through one of the 3 MCO plans, WellSense Health Plan, AmeriHealth Caritas, and New Hampshire Healthy Families. Children in Medicaid, their dental benefits are covered fee-for-service, so directly paid by the state in our fee-for-service program. And then the adult dental program, as required in the legislation that authorized the coverage, is administered through a managed care plan, which is currently delivered by Northeast Delta Dental for adults. I'm going to turn it over here to Dr. Chang.
Good morning, Mr. Chairman and member of the committee. I am Barry Chang, Medicaid Dental Director. The dashboard in front of you, it's a current snapshot of the adult dental program. At the current time, we have 217 unique providers. 2023, we started with 79 providers, so that network has grown over the years. We do have border unique providers from Massachusetts, from Vermont, and from Maine. The mobile event, the Severe Dental Van, it has grown from 1 van 2 days a week to 2 van 5 days a week. At the current time, we go to 15 mobile sites in all New Hampshire 10 counties. You grow from about 100 events from 24 to 439 events at the current time, and we have served about 5,500 members. The van consists of a dentist, a hygienist, and support staff. They provide preventive, restorative, and extraction services on the van. So next page, you could see the map of the mobile services to the state.
And the following slide, slide 6, is a current snapshot of overall utilization of dental services in the program. So to date, over 30,000 unique individuals have been served by the adult dental program. You'll see in the graph here, the blue or darker line at the bottom represents adults and their utilization of dental services since the start of the program, which is the dotted line. And we just included children just as a point of comparison. In every state, the utilization of dental services in the child population is far greater than adults. Any questions? And then the following slide, slide 7, we had received questions in prior presentations to this committee related to emergency room services and the interaction of this program with emergency room services. So the department had the opportunity to do some data analysis, thanks to the clinical direction of Dr. Chang and our analytic team. There's 3 charts here. The leftmost is showing you the rate of utilization of dental emergency department services, which you'll see among adults on the leftmost side has decreased before and after the introduction of the adult dental benefit. The middle graph labeled potentially avoidable ED rate, that's looking at emergency department use rates for any avoidable reason, so not just dental related services, but any diagnosis code that could indicate it was an avoidable trip. That's actually increased overall among Medicaid adults. And the total use of the emergency department for any reason all the way to the right has also modestly increased among Medicaid adults. So while this analysis did make us think we probably have some work to do overall on emergency department use and make sure we're managing that well in our adult population, it was gratifying to see that when looking at dental related trips to the ED, that's moving in the direction we want to see.
Additional to that, we have done a lot of outreach to the ED space. We have put up handout, we have put up poster in the ED space. So for the ED staff and for patient, they could see that. If they have a non-traumatic dental condition, but they're ending up in the ED space, they should contact Dental Quest, which is the dental organization with adult contract for care management. Typically in an emergency room for a dental condition patient, usually a prescription of antibiotic and an instruction to go see your dentist. That's usually what happens. We also secure or identify point person from the Dental Quest team, as well as the support staff in the emergency room for point person. So if there's a dental issue and the patient needs to navigate for care management, we know who the contact person are. And there's also a teledentistry component to this. It's 24/7. It's staffed by 2 full-time dentists. So if the patient have transportation issue, has issue getting a provider, they could request to have a teledentistry visit right away. And at least a dental provider could go over their conditions. It's not a perfect solution, but it's a solution for the patient to have more knowledge on their condition. Any question on that?
Senator Long.
Thank you, Mr. Chairman. With respect to children, is it the baby teeth? Do we have data on whether it's baby teeth or their second grown teeth that we're fixing?
So it's a combination of both. Age 11 and under, usually we're talking about primary baby teeth. Then anything older, it could be a combination of permanent and baby teeth. So it's a combination of both.
And a follow-up, if I may. Follow-up. And they're pretty similar. You know, they're like a 50-50 type or close to it.
I would say so.
Yeah.
For the primary teeth, the clinical approach will be different versus permanent teeth. Permanent teeth will try to save that. You know, for older kids, its primary teeth are falling out. They might need to be extracted. So the approach will be a little different. But I would say 50-50.
Okay, great. Thank you.
Senator Rochford.
Thank you, Mr. Chairman. Just want to look at that graph on page 7 to make sure I'm understanding it properly. So, if I think I heard what you said. But that middle chart, is that saying that 19% of all ED visits are avoidable?
No, sorry.
Okay.
It's a utilization rate, so it's 19% per thousand claims per thousand members. So
19% per
thousand.
Per
Yeah.
thousand. Okay, so we've got a decimal there. Okay. So we're gonna move the decimal over. All right, very good. Thank you.
Yeah, I'm sorry. It's 19 claims per 1,000.
Yep. All right.
Yeah.
Very good. Thank you.
Representative Woods.
Thank you, Mr. Chair. You offered some what seemingly is very good numbers about dentists participating in the program. That sounds very encouraging. Nevertheless, it sounds good, but is it adequate? Is there still, to adequately serve this population, we would need twice that number? Or is that number really adequate to serve the population that we're trying to address?
It's a great question. The beginning of the program was really focused on number of providers who've signed on to the network. And I think, as Dr. Chang covered, we've made really good progress on that growth. I think another aspect to access, right, is availability, because as I think many of us appreciate, different dentists have different appointment availability in general, and so our focus now is we still would love to grow the network. I think we do need more specialists in particular, and I'll let Dr. Chang make some targeted comments there. But I think it's also now focusing on, for the participating providers, is the program supporting them to the maximum extent so that they may see as many Medicaid members as may need treatment. And I'll turn it to
If I could
please.
interpret, that means it's not quite adequate you need a lot more.
We need more access
Okay.
to services. Yeah, I would say I don't have a number of, we need X providers, but yes, there's more to be done on growing the network.
Follow up.
Okay. What is the churn among the providers? In other words, are the providers joining and participating and staying, or are they dropping out and increasing that recruitment problem?
There has been churn in the network to date. We can come back with some more precise numbers. I think if you exclude dentists who have retired or moved out of state, I believe it is, less than 15 instances of like a network termination since the beginning of the program, but I can get those precise numbers and provide them.
And coattailing onto that, what are the programs in place for you to incentivize more dentists to participate?
I would say patient access rate has improved about 22% year to year. As Olivia mentioned, the specialists are something we struggle with, particularly the oral surgeon. Last year we had 19. Currently we have 15. It's difficult to recruit that specialist. It's one of the major hurdle we have to jump through. From my understanding, on the demand, sometimes patients have to wait for a month to get in. So that's something actively we're working on for recruitment. I think so far recruitment or enrolled Medicaid dental provider are stable. The number of termination, it's not a lot, but we're getting new provider onto the team. But it's also for those practice to see more patients. It's nice you're enrolled, but if you're not seeing patient, that sort of does not help the populations. And we have increased the fee schedule on preventative, on restorative, 5%. We also have increased dental lab fee for the practice. After COVID, dental lab fee skyrocketed. So we want to make sure that providers are not losing money.
If I may.
Yes, go ahead.
You said dental, and I'm not understanding the word you said after dental. The word that began with L. Dental.
Oh, dental laboratory.
Laboratory. Okay.
So if we're making crowns, if we're
Yep.
making dentures, or
Thank
making
you.
partial dentures, it's something that we don't do in-house. We
Right.
send it
No,
out
I
to
just
the
didn't
lab.
hear the word correctly.
Sorry about that.
So I was having trouble figuring out what we were talking about.
Let me speak
Thank
to
you.
a couple of possibilities that I know of more from working with family practice medical people. One is loan reduction. You give me a day a month in your clinic, we will do such and such to get your student loan reduced. The other is if this is ethical, to have fourth year D students be in the van as the dentist, as part of their training, as part of loan reduction, as part of. So to both of those, is either or are both in place, are being considered.
With the rural health transformation project, one of the initiatives is definitely try to increase residency in New Hampshire. Currently, we have 2 residents for the whole state, dental resident for the whole state. So we definitely want to increase activity on that front. It's also about provider incentive, about loan repayment. We're working on possible housing assistance to get more provider into New Hampshire. And the focus will be on the oral surgeon, but we need more dental provider in the state. We don't have a dental school in the state. So another major initiative is thinking about creating a dental center or a dental hub in the state. We could get dental students, we could get dental resident, we could get dental specialty resident, we could get CHW, we could get behavioral health staff, all in the same space. That will increase access and hopefully will grow our own dental network workforce. So that's in the grant itself. It might take some time for that to play out.
To make one just comment, I think that is sort of one possible direction. The rural health transformation initiatives are still obviously being refined in the sub-awards to the hubs identified in the grant, but developing the dental workforce is named objective.
What we do at the facility I'm part-time CEO of is bring in on rotations students, not only because they need it and we love teaching, not only could we use the extra set of hands, but we are quietly looking at people to see, would we want to bring them back on staff? And I could see a dentist who wonders about what kind of a partner or new graduate do I want? Someone coming in under this might serve alongside him or her, but know it or not know it, being interviewed at the same time. And that could incentivize a dentist who wants to have real life interviews of potential partners. That's what we do.
That's a great point. Appreciate that.
Thank you. Any other thoughts? Doctor, do you still practice clinically?
I do not.
You do not. Okay. Thank you. Thank you for your presentation.
Thank you.
I almost want to vote on something, you know. How many liked that presentation? You know? Well, it's going back to just voting on minutes again.
We voted on
We thought to the Medicaid thing.
We did, but now it is going back to, okay. And let's see, what do we have? Health status of rural residents triennial report. Danielle Hernandez, Administrator, Division of Public Health Services.
Good morning, Chairman Pearson and members of the committee. Can you hear me?
Yes.
My voice projects, I'm not surprised. I'm Danielle Hernandez, Administrator in Rural Health and Primary Care at the Division of Public Health. I'm here to present the health status of rural residents in New Hampshire. And as Chairman Pearson said, this analysis is produced every 3 years together with the division's health statistics and data management team. So does everyone have the packet in front of them? That starts with a slide title, health status of rural residents. We will be going through this packet today during the presentation, and then it also includes an appendix with all the graphics and data tables if there are any data wonks like me who like to dig into the detail. Okay. All right, so before we get started, I'm just going to quickly go over the agenda. I'm going to review the introduction and purpose, New Hampshire's rural definition, our analysis methodology, key findings, and then the following significant health status measures. All right, so page 1 is the introduction. The mission and function of rural health and primary care is primarily to strengthen healthcare access in medically underserved communities. And we know that in New Hampshire, many times those underserved communities are in rural areas of the state, right? This presentation is a statutory reporting requirement of the State Office of Rural Health, or the SOAR, which is what brings me here today. And this analysis aligns nicely with our primary care office community health needs assessment. This is a grant requirement under our office. So while there's no national standard for measuring the health status of a population, it is widely accepted that the best way to do this is by using primary care measures, right? With primary care being the first point of contact, facilitating care continuity, and care coordination. So we use primary care related indicators to assess the health status of rural residents. So the purpose of this analysis is to assess geographic differences in health status across population, access, and utilization measures in New Hampshire, identify geographic areas with elevated health and primary care access burden, support data-driven health planning, policy development, and resource prioritization efforts, and inform statewide and regional planning initiatives. On page 3, we have the geographic definitions. And I know I say this every time for these reports, but as a reminder, at the division, we usually report data at the public health region level instead of the county level, because public health regions are communities with similar public health needs, service delivery patterns, and planning priorities. Basically, it's just a better framework for regional public health reporting than county boundaries, which we know are really just administrative boundaries. New Hampshire has 13 public health regions and 10 counties, so they don't always align with each other, and really just, again, reflect how residents access healthcare and public health services in the state. Page 4 are geographic definitions. The division defines rurality using HRSA's Federal Office of Rural Health Policy, or FORPS rural definition. This is based on census tracts, and this makes a lot of sense because FORPS definition is the federal standard for determining eligibility for rural health grants and programs. Rural classifications are aggregated to towns, counties, and public health regions using a population-based approach. So the rural status representing the largest share of the population is assigned. And as an example, Dover has both rural and non-rural census tracts, but because about 75% of Dover's population resides within a non-rural census tract, Dover is classified as non-rural. Okay, so the health status indicators selected fall into the following categories. We have demographic and socioeconomic characteristics, which is what we call our population risk factors, barriers to care, geographic infrastructure, workforce availability, preventive care, which includes screening and early detection, healthcare utilization and health outcomes, and then specialty populations, maternal health and behavioral health. All right, page 6 has the table that includes all measures found to be statistically different by rurality or public health region that I'm going to highlight today. You will see that some indicators will only be on the rurality table if the public health region confidence intervals are too wide, which really just translates to the estimates being less precise, less reliable, and some only on the public health region table if the difference isn't statistically significant by rurality. Slide 7 shows the data sources and data sets used for this analysis. American Community Survey, BRFA's, New Hampshire Cancer Registry, All Payer Claims Database, the New Hampshire Health Professions Data Center, which I oversee at the division, Healthy Homes and Lead Poisoning, OPLC licensure list data, hospital discharge data, and vital records. All right, finally, a more interesting slide here. The analysis revealed several key findings. Rural residents generally experience worse outcomes across measures of population risk, healthcare access, utilization, and health outcomes. Variation across public health regions is often substantially larger than aggregate rural, non-rural differences. North Country and Winnipesaukee consistently demonstrate elevated burden across multiple domains. Substance use-related hospital utilization is an exception, with highest rates concentrated in Greater Manchester. And you'll also see that Upper Valley in this analysis is generally an outlier with better rates in other regions. I know that this doesn't surprise any of us given, the strong Dartmouth health infrastructure and health system in that area. All right, moving right into demographic and socioeconomic characteristics. Slide 9 has the population characteristics by rurality that may impact access to, utilization, and delivery of healthcare services. And I just want to mention, because this is our first rural table, that all rurality tables will be in this format, with the percent difference being how rural compares to non-rural. Rural rates exceed non-rural rates across nearly every population risk indicator. Rural residents are more likely to have a disability, veteran status, and financial barriers, and less likely to have a 4-year college degree or higher. On slide 10, population characteristics by public health region, and because this is our first public health region table, I want to note that the public health region tables will be in this format, with the percent difference being how the highest rate compares to the lowest rate in the state. And this table does a good job illustrating how pronounced the differences can really be at the public health region level compared to the rural, non-rural aggregate, right? We see that the percentage differences are greater than 100% here. Across most measures, North Country, Greater Sullivan County, and Winnipesaukee report elevated population risk factors, while South Central and Seacoast report lower rates. And these graphics can be found on pages 26 to 33. And if you do turn to those pages, you'll see that that's how, there's a number of them, 30 to 40 pages, I would say, of them. But it's nice to get into the detail if you would like to do so. All right, moving into healthcare access. Barriers to care by rurality. We found that travel times to primary care are predictably longer for rural populations due to greater geographic barriers, right? Lower primary care utilization by visits per year in rural compared to non-rural, and rural residents face greater internet access barriers.
One thing that surprises me here, if I'm seeing PC correctly as primary care rather than that. Oh, I see. I'm sorry. I was reading it backwards. It makes perfect sense now. Okay.
Great. Okay, so we see that rural public health region, on slide 12, by public health region, they generally experience greater barriers to primary care access, including longer travel, lower primary care utilization, and higher rates of limited internet and transportation access. Go ahead, Representative Weber.
Representative Weber.
Thank you. I'm anticipating here, but you know, I've got all this data that's the lowest and the highest, and my area hasn't been represented as either the lowest or the highest. And my really brief look at those slides in the back part, there's just a rural and a non-rural place. And I'm wondering, is there, just as a preview of coming attractions, is there anyone where that gives the actual values for all 12 or however many of the districts?
That's right. So all of the graphics have the first row is how it's broken down by rurality, but then the following rows list all the public health regions.
Okay, great.
Yes, and that's
so
why
that's in here somewhere.
Yes, yes. It's
Thank
hard
you.
to put them on data, right? Summary data tables. So I wanted to provide the detail for you to dig into. Yeah.
Thank you.
About 40% of primary care visits among Winnipesaukee residents have travel times greater than 30 minutes. And North Country stands out as a rural exception with short travel times, high primary care utilization being the second highest visits per year, and second highest primary care provider supply rates. You can turn to pages 35 to 40 to see that detail. And while this may seem a bit counterintuitive, North Country has benefited from significant healthcare workforce and access investments. And that's because they're oftentimes tied to federal shortage designation status. North Country has a HPSA, a health professional shortage area. So they're able to build these community care models like community health workers, CHW care coordination, mobile integrated health that help to address these access barriers prevalent in North Country and areas like North Country that have high rates of no household internet or vehicle. Upper Valley has exceptionally high primary care and dentist supply rates, which I will show you on the next page. And this also sort of goes to Representative Weber's point here, why it's so important to look at the public health regions and not just by rurality here. So on the left, this is hard to see. So if you want to see bigger charts, you can turn to pages 40 and 41. But we have primary care provider supply rates in the chart on the left, and dentist supply rates in the table on the right. But what I want to draw your eye to is the circled rate on both charts, showing how Upper Valley exceeds the rates of all other public health regions by a large margin. And it pulls the rural aggregate up.
The senator is trying very hard not to be proud at this moment.
Yeah, definitely in workforce, which unfortunately masks the full extent of primary care shortages, right, in rural New Hampshire. But again, the slide illustrates why analysis at the public health region level is so important. It allows us to identify areas with high healthcare access needs so that we can target limited resources to those areas. And a fun fact here, so the dentist supply data was actually the driver to evaluate Greater Sullivan for a dental HPSA, which we just recently received approval for to designate the southern towns of Claremont and Newport. So that's sort of a nice little success story that came out of the Health Professions Data Center data. All right, healthcare utilization and preventive care.
Representative Weber.
I was just saying, thinking that I'm on the cusp between Greater Monadnock and the Sullivan, and what I'm being confirmed in my notion that I had already is that the next place that we really need to look at is the southwestern corner, where we are very close to a lot of more developed areas and more access, but we're kind of limited in what's happening, and the limits are getting greater because we have a significant number of institutions that are currently pretty wobbly.
Yeah, that's exactly right. And what's helpful about this, not just looking at it through the lens of the public health region. But when we do it to understand better, the natural access patterns, it allows us to see sort of those rates there, but to dive in more. And my office also coordinates the federal shortage designation for the state, as I said. So working closely with our technical contractors, we're able to really do a thorough evaluation there to say, generally speaking, we know when we talk about Upper Valley and Greater, there can be a comprehensive healthcare system, right? That's there, that's available, but it's some areas are also isolated, right? They're distant enough that they don't reap those benefits of that system, and so we're able to sort of be able to pull that data out and get resources there to secured there to increase healthcare access where we can. Okay, so healthcare utilization and preventive care on slide 14. Preventive care by rurality. Rural residents report lower rates of a dental visit within the past year and lead testing among 1 to 3-year-olds. And by public health region, lead testing rates vary more across rural public health regions where we see rates between 57 and 85%. Than non-rural public health regions where rates are a little bit more consistent, right? We see rates between 73 and 81%. Central New Hampshire, Carroll County, and North Country have the lowest lead testing rates in the state and are the only public health regions with rates below 70%. Healthcare utilization was also measured by prevention quality indicators, or PQIs, and ambulatory care sensitive conditions, or ACSCs. And these are measures of inpatient admissions and ED visits that could have been avoided with timely access to primary care. Rural residents have lower hospitalization rates for preventable medical complications, but they have higher rates of preventable ED visits for acute and non-traumatic dental conditions, which may in part be explained by gaps in timely outpatient acute and dental care, right? No surprises here. We know that outpatient primary care isn't always available or accessible in rural areas. And so sometimes for these communities, especially in the evenings on weekends, for convenience sake, they're accessing the ED. By public health region, we see North Country consistently ranks among the highest statewide for preventable ED utilization. And Greater Manchester consistently ranks among the highest statewide for hospitalization rates. The rate of chronic preventable ED visits is driven by exceptionally low rates in Upper Valley. And while we see Stratford has the highest rate, and that's the third row from the bottom, you can see the rate there, North Country and Winnipesaukee also rank among the highest statewide. And you can find those graphics and charts on pages 50 to 52.
Senator.
If I may, a quick question. So this is a little perplexing to me because in a couple of the previous slides, the North Country had great access to primary care. The drive times were shorter. There were more providers there, yet they're not utilizing primary care. They're utilizing the ED at a higher rate. What do you attribute that to?
Well, like I said in the last slide, it's hard to know. And I will say, this analysis does a really good job answering, the what, but not the how or why. And so I don't have the definitive answer, but I'll say, just because those services, while they try to create greater access for those areas, it still, isn't as accessible as we have in non-rural urbanized areas. And so, the ED utilization, it may just be, again, sort of the default to access care, that should be at an outpatient primary care practice. But because of, the culture, the way of life, and the access that's available at the time they need it, they may wind up in the ED instead. But it's hard to say. And the other part of it is, we know that it's not just limited to geographic access, right? Like these indicators are also influenced by socioeconomic indicators, right, and challenges, disease burden. North.
And that kind of leads into my next thinking is the North Country also has the highest rates of Medicaid. If they're using the ED as a primary care stop, it's very, very expensive.
Right. Right. I agree with you. And unfortunately, I don't have the answer to that. Yeah.
Thank you.
Yeah.
Thank you for identifying Kingston and Hampstead as South Central. We are not Seacoast. You get it. Everybody else says we're in the Seacoast. I haven't seen the ocean in a long time.
Exactly.
Thank you.
Let's see from where you are. It'd be 12.
That would be a serious problem. Yeah.
For health outcomes by rurality on page 17. Elevated blood lead levels remain a concern statewide, with rates among young children nearly twice as high in rural populations as in non-rural populations. By public health region, rural regions generally show higher elevated blood lead levels between 5.4 and 9.8 micrograms per deciliter, and non-rural regions lower rates, most between 0.9 and 3.6 micrograms per deciliter. Late-stage breast cancer diagnosis may reflect disparities in timely screening and access to care. Because this report focuses on differences in access and utilization in primary care, we looked at the proportion of breast cancer cases diagnosed at late stage, which tells us more about screening and routine care, right? And we see that there are regional differences in when breast cancer is detected. So in central New Hampshire, there's the highest rate at 35% of cases detected late stage, nearly double the rate found in Upper Valley at 18%. Population health outcomes by rurality. Rural residents experience modestly worse population health outcomes than non-rural residents. The death rate is statistically higher, and the life expectancy is statistically lower for rural residents compared to non-rural residents in the state.
What do you mean by death rate? I thought it was one per person. No, really, I don't know what it means in this context.
It means, oh my goodness, it means.
Shut 9 off for a minute. Okay, go ahead.
It means the rate of deaths per 100,000 residents in the population, which is also age adjusted, I will say. So we're not saying, so we can compare apples to apples here.
Okay.
So it's not, it can't just simply be one region is older and one is younger. It's age adjusted to say, and it doesn't tell us why necessarily. We're just sort of using,
okay.
Right?
I'm just trying to get my head around what. Okay,
yeah,
thanks.
Yeah, so, right. And by public health region, regional variation in mortality rates is substantially larger than aggregate rural, non-rural differences. So if you look at North Country and Winnipesaukee on page 56, they have mortality rates that are statistically higher than all other public health regions statewide. We see that Upper Valley outcomes are the best statewide, right? Life expectancy varies by more than 6 years across New Hampshire regions, with the highest average in Upper Valley and the lowest in North Country and Winnipesaukee. Specialty populations, maternal health on slide 19. Rural residents continue to have substantially higher rates of smoking during pregnancy than non-rural residents. Rural areas experience statistically higher rates of post-term delivery, which could suggest differences in pregnancy management and OB care access. By public health region, North Country and Greater Sullivan County report the highest smoking rates during pregnancy statewide, both exceeding 11% of live births. North Country stands out with a teen birth rate more than double the aggregate rural and non-rural rates at 12.7 births per 1,000 females aged 15 to 19.
And by comparison, South Central, Roxette.
Right.
Hampstead and Kingston.
Substance use by rurality, rural residents experience significantly lower rates across all substance use related acute care utilization indicators. So not necessarily substance use prevalence itself, right, but ED and hospital utilization. When looking at mental health, by rurality, rural residents experience higher rates of self-inflicted harm ED visits than non-rural residents statewide. And slide 24 illustrates mental health by public health region. Mental health indicator rates vary considerably across New Hampshire public health regions, with the highest rates concentrated in several rural regions. Capital area and Winnipesaukee experience higher self-inflicted harm ED visits than all non-rural public health regions and aggregate statewide rates. Suicide mortality rates are generally higher across rural public health regions, but just a note of caution that small numbers really do limit statistical precision there. But the suicide rate in North Country is statistically higher than the aggregate non-rural rate. That is a lot of data. It's a very technical analysis. It's hard to summarize in just a few slides, but that's what I have for you. I'm happy to take more questions. I have my business card to hand out, and of course, I'm always happy to receive inquiries and follow up with information when needed.
Do you, plural, work also on why and now what, as well as the data? Because this is, I mean, for people who love maps and charts and things, this is fantastic. I'm going to keep this.
We try to, in a statewide effort, right? We don't want to. The State Office of Rural Health, is really the hub for information sharing, dissemination, bringing partners together where we can. But we do work very closely with organizations in the state that have a better handle on, what's really going on, and they're, more embedded in the community to understand, the needs there. We work together with the Commission on the interdisciplinary primary care workforce, and their mission is to really plan and advocate for policy change to increase the healthcare workforce and healthcare access. We work very closely with our Primary Care Association and the Healthcare Workforce Coalition that sits behind us, as well as, the pipeline organization, so the AHECs, right, the Area Health Education Centers. So, our office obviously has our responsibilities, our duties, our deliverables, but we really do try to have a concerted effort with other experts around the state to also figure out, not just the what, but the why and how.
Representative Weber.
Thank you, Mr. Chairman. Thank you very much for all of the questions and all of the data, which is really fascinating. I'm wondering, one of the things that I heard a lot about this past year was the departure of some of the providers for the Medicare Advantage programs. And in my area, which is the Monadnock region, Southwest, I can never remember what we call it here, but the issue for many of my constituents was that the plan that was remaining did not have a contract with the provider, being Dartmouth Health, that provides almost all of the health care in our region. And I wondered if you saw effects ranging from Upper Valley all the way down, at least the western side of the state, ranging from Senator Rochford's part down to mine, whether you could see whether that had any impact or not, or is it too early to see that, or maybe because you're not quite so focused on the why, but I wonder if numbers are showing up in those areas that might concern you. Because I know it was a huge concern for my constituents when they were trying to figure out how to get coverage that covered the providers in our area.
Yes, and without speaking directly to that variable, because I don't work in the Medicaid office, and I can't say. My office does also issue and present an annual report on the healthcare workforce in New Hampshire, and in that report we do an analysis of the primary care provider supply rates in the areas. And so we've done this now. This will be our third consecutive year doing it. And so we're able to see changes that way and provider supply by population. But I will say that generally speaking, if we're talking about physicians, we know that they are leaving rural areas, even though there is a minimal net gain of physicians every year that come into the state. They're not going to rural. And so we are seeing that, and we do track it. I don't have, the statistics in front of me now, but I'm certainly happy to follow up with you and provide that information to you.
And if I can just, as a follow-up comment, it was very interesting to me to find that we had gotten ourselves into a place where we actually had providers and people had insurance, but it was still a real barrier to care because they didn't align. And I just want to alert people that is an issue that I suspect isn't going to get better going forward. So I just want to be sure that we're all kind of keeping that in the back of our minds, because it was our area this time, but it might be somebody else's area another time. And there have been other areas that were impacted at one point or another.
Right. I appreciate that, and I'll definitely keep this in mind during the next presentation I have for the healthcare workforce to address it.
Thank you so much for taking Representative Rochford's question.
Senator. I couldn't resist. I couldn't resist. I know it's not misaligned, so I'm just giving you a hard time, Mr. Chairman. Thank you. I'm parked on the ED utilization rate. I can't get off of that, and I'm wondering if you have the ability for an overlay on this data. I know, just speaking for myself, the prevalence of walk-in clinics, urgent care clinics, as they relate across the state, and is there a correlation between access? Because I think you brought up a fine point, and I think Representative Weber did too. I mean, sometimes access and payment models don't necessarily align. Right. Is that a barrier? But I'm also curious to see, are we seeing better PCP utilization and lower ED utilization in areas that have more access to walk-in clinics, urgent care clinics, things like that? And I don't know if you have the access to that, if you can pull a license and overlay that, but I think that would be very interesting to see if there's any correlation there with that type of access versus utilization of some of these higher price services.
Yeah, I appreciate that, because I presented this analysis to the Primary Care Commission, and that exact question came up. And so now I know the next time around we will be doing that overlay, and we are able, through the Health Statistics and Data Management Office, able to pull out those claims of urgent care, convenient care visits. So we'll sort of see how that compares and overlays across areas, and whether that makes a difference at all. Yeah, I appreciate that.
One parallel to the senator's comment, the facility I help run is a standalone, which is a dinosaur. And I can just imagine individual doctors 60 years ago going to, name a rural town, setting up shop, living the whole life, and retiring from there. But since running a doctor's business isn't the same as being a doctor. A lot of doctors don't want to go to a place where they are a standalone, hiring the staff, supervising the staff.
Right.
Might not there be established consortia where there is a PCP group in different towns, but with a central management system so the doctors can be the MD and DO that they train to be and not have to run a company. That is why some med students I've talked to said, I'd love the life of a rural town, but I'm not going to run a company. So throw that in the hopper.
It is, it's an interesting question, and I don't have the answer, but I know that there's a lot of good work going on, in the ground. And the other benefit of the public health regions, they're not just boundary areas, they are networks. And so, right, I think that those groups also think about that and how to, right, like how to sustain and how to keep care consistent when it first exists. And I do also want to add, this will come with the next report, that, when we talk about primary care, right, we aren't just restricting, we're not limiting it to physicians. In this state, APRNs have the same prescribing, right, capabilities, high scope as physicians. And so in many of those rural areas, even though we're losing physicians, we're gaining APRNs.
I have one and getting another one. I'm very familiar with their work. Yeah.
Exactly. And then the other question is, how do we bring back those locum tenens, those part-times, those that just retired, that don't want that want more flexibility, and perhaps in that administrative role where it's not, they're less prone to burnout, let's say, and there's more shared care across, and just a better way of doing it. But we'll see what's to come with the Rural Health Transformation Program also, right, and these exciting new initiatives in the state.
Saying nothing further, thank you so much. And one more thing, committee, before we go, I have a tentative, big, fat, juicy, beautiful agenda for August 28th. And you may say, why should we meet in August 28th? And the answer is the September, October, November, and maybe December meetings will be probably more than 2 hours because we got a lot of stuff to do this fall. So I'm quite happy to sign in for mileage on August 28th. And if you can too, would appreciate that. Just let me know. The only thing we'll probably have to vote on is the minutes, and they can be deferred, even though we have this great newly committee acquired skill in voting for things. If you can make it, that's great. And if just let me know one way or the other. Thank you.
Will that be at 9:30?
It will be at 9:30. And we are adjourned. You see,